I have used maybe 5 or 6 EDOFs. And, in Australia, the first one of the earlier ones that we had was the Vivity. And it was good in the sense that we had some experience with the kind of non-diffractive platform. But I would say my experience might be similar to a lot of my colleagues where the A constant was not optimal to start with. The outcomes are a little bit variable and it can take quite a while for the visual to settle. So the thing I like about the EMV is that the vision settles very quickly. The material has a high Abbey number. It's a hydrophilic material. And with the double C-loop haptic, it's very rotationally stable. So, of course, in Australia, we also use a lot of toric lenses through the roof compared to the rest of the world. And so it's important to have a lens platform that is rotationally stable. The other thing I really like about the platform is it's tried and tested. It's not new material. It's not a new platform. And whilst, I haven't necessarily used the platform for a long time, it's been around for a long time. So I can have confidence in that. It's a pretty easy learning curve with the injector. I like the way it's cylindrical, so it fits through the wound quite well. No issues there. So very easy learning curve. The loading, I have to say, it's very rare for loading of a lens issue to be a problem. With the RayOne EMV, things are more forgiving because it's an EDOF rather than a multifocal. The other thing is I find that I don't really have to counsel my patients about reduction in distance visuals, which with other refractive type lenses, we've had to say there might be some compromise in the distance vision or a little bit of distance blur. And because of that, I'm now using it, now that I've had some comfort with my cataract patients, I'm now using it actually in a more refractive sense for the refractive lens exchanges. So that's really exciting, isn't it? Because I feel like, it's where we may have turned patients away in the past, we have now more to offer for the lens lights. And in those refractive patients, I will blur them a little bit in their non-dominant eye and see if they tolerate a little bit of blur. And then I know if they're going to tolerate a little bit of micromonovision if it gets to that. So I can counsel them much more effectively about what I think I can get their near vision to if we do need to offset things a little bit. I will look at a couple of different calculations. The RayOne calculator I find to be reliable, but I like to cross-check that with keratometry. I use an IOL Master 700 as well as TK. And I think I am noticing a trend that the advice to go for the first plus, I think I'm noticing a trend that if you use TK, you don't need to be as aggressive with aiming the first plus. I feel like when I'm looking at my calculations that you definitely on the RayOne calculator need to be quite aggressive with aiming for the first plus.